So some of the messages in my presentation, I think, okay, it's already here. Repeat the ideas expressed in the introduction, so I'll be quick in them and devote more time explaining the practices we want to share with you. First, the context. As we all know, demand for care is growing. This is the particular case of my company. We see the monthly patient consultations in the last 3 years, and we can see that except for the pandemic period where we had these curfews, it's always going up and up. And if we had put, this is from 2019 to 2021, if we had put 2022, the trend is the same. So we have ever more consultations, and at the same time, we have an ever-growing waiting list, which is now of 25 days, which is particularly bad, taking into consideration that we mostly run private hospitals. In Spain, for those of you that don't know it, we have the public healthcare system that covers all the population, and then the private system, which is totally optional. People have to pay for it, and they essentially pay for it because waiting lists are smaller, way smaller than in the public sector. So for us, having a ever-growing waiting list is a problem, and it's a reason that we can think that shows us that demand for care is growing. I mean, we have the data and we have the growing waiting list. At the same time, as we have already mentioned, shortage for healthcare workers is a really serious problem. It was already a serious problem before the pandemic, at least in Spain, because many workers go to other European countries where they are better paid, a lot better paid. And now with the pandemic, it's even worse, and it is expected to be even worse. Right now, the expectation is that we have a lack of 5,000 doctors, and we will be having 9,000 in 2027, which is around the corner. And in some regions, we are seeing this news on the press because it's a big thing here in Spain. More than 40% of doctors are going to retire in the next 10 years in some regions. So we are facing a growing demand and less physicians. So one could think that, I mean, conditions for physicians are good because, I mean, we need them and we want to pay them a lot of money, but it's not exactly what is happening. It's the other way around. Basically, talking about the overall situation in Spain, they have less time per patient. Basically, managers are saying, so we have growing demand. The numbers I presented are of my company, but it's a summary of what's happening in the whole healthcare system in Spain. So as we are facing bigger demand, just work faster, devote less time per patient, see more patients in a morning, work more hours. And as we have already mentioned today, there's the burnout of all these physicians that are tired, are also unmotivated because of many bureaucratic tasks that they have to do, very trivial conditions that they have to see in lots of patients, and they cannot devote time to complex patients, and because patients express their frustration at them because of their long waiting lists. So this is the starting point. But as we saw in the McKinsey presentation, where's the good news? He was saying, okay, there are good news because our approach here is to try to think of, with the current resources, what other healthcare models can we provide that are both beneficial for patients, for doctors, and for the organization as a whole, using the current resources, and acknowledging that we will never have more doctors, we will never have, I mean, the resources problem is not going to be solved, so how can we work with what we have? So the idea is using existing technological tools, design case scenarios where things can be done better. And I will present you a few examples right now, okay? So that we can attract doctors and that we want doctors to want to work with us because of these new models that have nothing to do with traditional practice and that it might be interesting for them. And we want to promote these models not only for new physicians, but also for the existing ones so that they don't want to go to the competence or simply retire. But first of all, there is a warning. As we have said also before, digital transformation is a very risky concept. And it is risky because we have seen lots of examples where implementing technology instead of, only increases something for some stakeholder, but decreasing quality for another one. Let's put an example that has recently happened in the public healthcare system in Spain. They've substituted a lot of on-site or face-to-face consultation by video consultations, which is something that might work in some cases, but they've applied that for general doctors that sometimes see conditions that require physical exploration. Doing or delivering this tool has made no sense in many cases. Or let's think about, we were discussing this yesterday, the banking sector, where many people, especially old people, 20 years ago, if they wanted to do a basic operation, a transaction, they could go to the bank, do a small queue, talk to the person, and the service was provided. Whereas today, the only option is the digital, which for many people is fine, but some people are not good with phones or don't want to have a phone, so they simply cannot do something that 20 years ago was easy. Probably for the bank management, the new process is good, but it's not good for their clients. So the approach is thinking new case scenarios that are useful for all stakeholders, or at least not bad for anybody, okay? And we don't want to talk that much about digitalizing or about digital transformation, but about humanizing, although it's using technology to humanize. So let's go to the examples. Dermatology. It's where we have the biggest problem with waiting lists. 52 days currently in all of our hospitals. And I recall that we have 45 hospitals, okay? So 52 days of waiting list, which is really frustrating. And this provokes two problems. For many patients that have banal conditions, that little problems, for example, a small skin lesion that after 50 days, it's gone, and they end up not showing to their consultation and provoking other problems. And for patients that, for example, have skin cancer, they end up arriving really late to their first consultation and even facing questions such as, how did you spend that much time? How didn't you come before? Well, because he couldn't. So what's what we are doing right now to tackle this? And now, after explaining this, I'm going to tell you what we will do in the near future. So right now, the patient detects this skin lesion and demands a consultation. You can do it calling us or through our app or website. In all three cases, if he wants a consultation for dermatology, we ask the patient if it is for a few reasons. If it is for this, and this, we suggest you to go to the teledermatology. If the patient accepts, then we schedule an appointment for an on-site consultation where a nurse assistant will take a picture of this skin lesion, and afterwards the doctor will remote this assessment remotely. We'll assess this picture remotely. First benefit, the time for this on-site consultation is only 7 days. That is our current average. So in just 7 days, somebody is seeing the patient. only that it's not the doctor, it's somebody that takes a picture. And in 2 days, after the picture is taken, we have 98% of the cases are assessed before 2 days. These doctors, what they will do is check this image and do a medical report assessment and manage the business continuity. I don't know if you can see it, but in the first case, they discharge the 78% of the patients directly because they are very simple conditions, and probably with a treatment such as go to the pharmacy and demand this cream applied twice per day during a week, and if you don't have any problem, that's it. This applies to the 78% of the cases. You might think that some doctors or patients might not be happy because they are not actually seeing the doctor. But when you have a skin problem, what you need is to know a treatment and to know it as quickly as possible. Most people do not want to ask permission in their job to have time to go to the doctor just to tell them go to the pharmacy and buy this cream, okay? And this is the case for 78% of our patients. Then, probably most importantly, we have 10% cases that require surgery. In these cases, what we do is schedule an appointment. It's not the doctor that schedules it. The doctor only has to do one click in the system, and somehow administrative staff afterwards will see it and schedule an urgent appointment before the surgery. Here, what we have achieved is that all our patients that require a surgery have their surgery done in 14 days, whereas before we were having 52 days just to see the doctor on first time. So for these patients, especially these 3% that have skin cancer, it's 1,400 until now. For these 3% of patients with skin cancer, we can be saving their lives, or at least taking their problem a lot before than what we were doing before. And there's the third case, which we simply require the patient to come to the consultation room, and they will have to wait the waiting list. They do not have a severe condition and do not have a simple condition. These ones, probably, these 12% are probably the most unhappy with this process, okay? But at the end of the day, we have treated the bulk of patients which are easy conditions and the super tough patients that are prioritized very quickly. In all cases, patients will receive their medical report and next step in their phone, or in their computer, so they know what to expect. Everything is explained to them before before choosing the teledermatology option. There is an explanation of what this process is and what they should expect. Okay, I was saying before that these things should be good for everybody. So first of all, benefits for physicians. For simple conditions, they just need 2-3 minutes to address them, the diagnosis and treatment. I've put 2-3 minutes, but we have checked, and in some points it's 1.5 minutes because it's super easy for a dermatologist to see some particular cases. So this increments a lot the productivity of our doctors. I mean, just having the same doctors, we are able to see many more patients, just simply that in a different way. Apart from that, this higher productivity gives our doctors a lot more income. Probably each country has a different model, but in the Spanish healthcare sector, most of our physicians are not in our payroll. They are not hired staff. They are companies with which we reach an agreement. Each doctor will be a different company, and they work in our premises, and they do the activity. We invoice it, and we then reimburse their share. So they are paid by activity. So if you can see a quote below, teledermatology allows me to treat 60 patients in 5 hours instead of 20. Well, in the physical face-to-face situation, they could see 20 in a regular shift, whereas right now they can see 60, okay? So they earn triple the money with this system, or they could earn triple the money in some cases. Besides, they can do more surgeries. As we are detecting surgeries before, we can focus more time on surgeries and less time in consultation, especially for unnecessary or easy patients. Why do they devote less time? Why don't they devote 2 minutes in a physical consultation, in a face-to-face consultation? Because just for calling the patient, for the patient to come in, to talk about things that have nothing to do with their disease. They have their companion that normally does a secondary parallel consultation, especially if you come with kids. These things, at the end of the day, you spend your 15 minutes, and you just needed to assess this particular patient. So with this system, all these patients are really prioritized. I mean, the tough patients are prioritized, and you can devote your time for patients with skin cancer, call them, and instead of 15 minutes that would be the standard, as many minutes as you wish, because you can focus on them. And another important thing is the flexibility and the work-life balance. In the McKinsey presentation, we were seeing that the preference between money and free time has shifted towards free time. Here, we can offer them the possibility to address this from home, because they are seeing photographs and making reports. You don't need to be at the hospital because you are not seeing a patient. You could do it in the hospital, but you can also do it at home or in another place, and even schedule it whenever it's good for you. Probably you want to play with your kids until they are asleep, and then devote a few hours to assess 20 patients at the time that you want. So this offers a range of flexibility that in the traditional way is not available. And then regarding results for other people rather than physicians, for patients especially, the big thing is that everything is done before, from 52 days to 7 days. The report is in only 48 days, surgeries in only 14 days, and the fact that easy cases, they do not need to go to the doctor. They can do these things in a simple visit to a nurse assistant that is widely available, and it's a lot easier. Okay? We see that we have 41,000 episodes already done, so meaning that this is a big thing. It's not an experiment. It's a project that is working. How do we want to continue this? Well, the next step should be that the patient directly uploads the image to our app and the doctor assesses it. In fact, we tried to start with that, but it didn't work correctly. That's why we want them to go to the nurse. Because of, we don't have an artificial intelligence that tells the patient if the picture is well taken or badly taken. And at the end, we had lots of issues, and we changed to that other way. But we are addressing these problems using technology so that at least the system is able to tell you if the picture is okay or not, and we can use it, okay? So we would skip this nurse assistant, and we would go directly to the medical report, and hopefully reducing the time. We thought at the beginning that we would decrease the waiting list, and it's not happening, because even if we are removing lots of patients from the traditional waiting lists, new patients are coming. So as long as you open new time slots, in some hospitals even we have 80 days of waiting lists, and in some hospitals we cannot even measure it. because it's all the time booked. Everything is booked, and whenever you open new time slots, they are filled really quickly, so we cannot even measure this. But at least we are having a bigger percentage of first consultations that are more relevant, because easy cases are prioritized in a different way. And then on the right, we've showed another project where we are working, which is basically through artificial intelligence, we are creating an algorithm that should allow patients to have a pre-diagnose, and if required, to be appointed quickly to our hospitals. Okay, this is just one example of, let's say, new healthcare models that can be applied before the patient goes to the first consultation. But there are other examples that I have not brought here. For example, endocrinology. 30% of the consultations of the endocrinologists come because other specialists see a strange result in a lab test. And of this, 20% of the cases, patients have nothing. And the physician, the endocrinologist, only needs this lab test to assess it. He doesn't need even to see the patient. So we are applying already this system to devote 2 minutes for these patients and devote more minutes for the face-to-face patients that are more complex. Okay? Let's go now to a different case, which is after the first visit, after the consultation. I'm bringing the example of gastroenterology and remote assessment of biopsy results coming from samples acquired in an endoscopy. So the process would be, in the first consultation, the doctor would propose the patient to have a remote assessment in case they take some samples in their endoscopy. If the patient accepts, because here it's important that we always have to ask the patient. If the patient doesn't want any remote assessment, we continue with the traditional way. But if the patient accepts, then the doctor will perform the endoscopy, and in the case he needs to take some samples, what we will do is, what is the traditional model? You send the samples to the pathology department. In a few days, results are available, and some days later, probably 30 days later or more, you will appoint the patient to tell them the results. And in many cases, the results are that everything is fine. So we are making patients come for a face-to-face consultation to tell him that everything is fine. And the idea will be to say, if everything is fine, don't come. Just check your phone and you'll have the medical report. Otherwise, we will call you and appoint you, okay? Here, the risk is that when you receive the call of Quirón Salud, if somebody's calling you, you start being a bit worried, okay? But there are ways to say this message. Anyway, so the idea is that one. The doctor, in the new process, the doctor will see the pathology result without the patient in front, and they can see these results as soon as they are available, and not having to wait until the patient comes. That the patient would come after the long waiting list that we already have. So the doctor will assess it as soon as the result is available. In most cases, nothing. He will discharge the patient, and in other cases, there is a process to call this patient and schedule an appointment with the priority that the doctor says. If there is a cancer suspicion, the appointment will be totally urgent. If not, they will have to wait the waiting list and appoint in a normal way. Okay? And of course, as we are talking about private practice, we have to bill all these remote assessments. And we have already a system in which we can bill these appointments even if the patient didn't come, because there is a medical report that proves that there has been a medical activity in place. Okay? And And that's it. And in all cases, patients will receive their medical reports in their phones. This case, I've just put this biopsy, but it is applicable to other specialties, and it is applicable to other lab tests. For example, we are using this also in gynecology for the cytologies taken in the consultations, for mammographies. Gynecology, the cytologies and mammographies are requested by standard protocol, not because there is a suspicion of anything. So in most cases, women have nothing. So what we are doing, instead of asking these women to come to a face-to-face consultation to tell them that you have nothing and everything is fine, we simply send them that report to their phone and tell them that if she needs to come again, we will call her. So it's basically the same model. Benefits here, again, efficiency. Just to check the pathology report and assess it is very quickly. If you don't have to be talking about the life of the patient, calling him, greeting him, or saying that he looks great, or all these things that happen in the face-to-face situations. And also, there is a higher clinical value of on-site consultations. You are not doing as many consultations just to give just to assess a result and give a result or a paper to a patient. Your consultations have higher clinical value because you are seeing more first-time consultations, less follow-up that have less value. And again, what we were saying before, flexibility. We were seeing that there's a gynecologist in a hospital that was telling us that in 2.5 hours he had been able to assess more than 40 cases, which is absolutely impossible in a face-to-face world. And he had done that from home. So it opens new possibilities of organization. And even if we work as a team and not as particular physicians, we can even this is optional. You don't have to do it, but it's an option that before we didn't have. You can devote some doctors that, for example, want to spend more time at home for whatever reason to check more of these patients, and other doctors to focus on surgeries, for example. Whereas before, it's one doctor and their patients, and he manages his patients, and there's no teamwork. Okay, so this offers these new possibilities to organize. For patients, they don't have to come to the hospital just to receive a paper telling that everything is fine. So less visits, and it's a better quality of care in the cases that something suspicious is found. In case of cancer suspicion, etc., things are accelerated. And for the company, we're happy with the rational use of resources. With the same doctors, we can see many more patients, and we have a higher economic value of the consultations because follow-up consultations tend to be paid less than first visits. So these are the examples. And now let's go to not before or after, but for chronic patients or patients that we want to see during a long basis. And the example here is the cardiology, the remote monitoring.
Rafael, can you keep it to like 5 minutes to respect the timing? Thank you.
Of course, of course. And I'm glad you said that because the summary of this project, we assess patients that have blood pressure problems and that are chronic patients. We ask them if they can, these patients normally what they do is that they have a blood pressure monitor at home, a simple one. They tend to take their tension measurements, write them down in a paper, and afterwards bring that to the doctor every 3-6 months, etc. But the doctor, or even not even writing them down, and the doctor doesn't have information. So the idea right now is we allow them to transcribe their measurements to our portal, and this information will go to the doctor. But the good thing is that we have put a case manager that can check all this information and an alert system in case there are measurements that are too high or too low of the standards. And in these cases, there are protocols where there is a real-time monitoring where there are protocols where we can call the patient, ask them to, for example, take the measurement again or do something else. And in case something is really wrong, we can schedule an urgent appointment, which is something that without the technology we couldn't do, because nobody would notice that this patient is having a severe condition. Okay, so the summary of this project is this: basically the alert system managed by case managers, and the fact that when the patient goes to the doctor, instead of having one measurement every 6 months, he has probably a daily or weekly measure with a graph, and he can assess with a lot more information. Here, the good thing would be that physicians have a lot more information, and especially that we control patients that need to be controlled. And we know the problems when the problems happen and not 6 months afterwards. And as well, we don't need to see these patients that often, because if there are no alerts and they are measuring their thing, it seems that everything is fine and there's no need to focus on them. And just to end up, we have lots of other tools that we can apply for processes, but sometimes we have the tool and we don't know what to do with it. So the question here is, devote your time in design case uses where with your current tools you can make a change. For example, I will focus on this one on the right, cardiovascular risk prevention. We have devoted a tool where for every zip code we know the percentage of people who have a higher probability of cardiovascular risk prevention. But we don't know what to do with this information. We haven't applied any campaign or anything. We even do not do primary healthcare. We are secondary healthcare. We are hospitals. So we have tools, and I'm sure if somebody sits down and thinks what to do with this, we will come up with a new case scenario like the ones I said before. But the fact is that the conclusion is that we have it all to change. So let's go faster.